Well, good morning, academics and peers. Thank you so much for taking the time to attend my final honours presentation. My honours project is entitled Investigation into Complementary and Integrative Medicine Practitioners' Clinical Experience of Intestinal Permeability. Now, to fully comprehend the research that we've done, I first need to give a bit of a background to both complementary medicine and intestinal permeability. So it's been estimated that 68% of individuals have seen some form of complementary medicine practitioner, with another 16 to 55% seeing an actual complementary and integrative medicine practitioner. Now, these practitioners, such as naturopaths, nutritionists, and Western herbal medicine practitioners, see a large variety of conditions within clinical practice. And about 80% of them have illustrated that their clinical interest is actually digestive health. Now, through this clinical experience and deductive reasoning, complementary and integrative medicine practitioners might have developed a new understanding to intestinal permeability, to assess digestive health and potential treatment options. Hippocrates, the father of modern medicine, once said, "All disease begins in the gut," and so right he was. The gastrointestinal tract is the largest interface between the external and internal environment. This interface is approximately 400 square meters, and this surface area is where we actually absorb nutrients while preventing the absorption of potentially toxic chemicals and antigens. Now, naturopathic philosophy incorporates the modulation of gastrointestinal health as a fundamental principle for optimal health and well-being. One aspect of gastrointestinal health is intestinal permeability, also known as leaky gut. All right. Increased intestinal permeability involves the loss of integrity between the epithelial cells. If you can imagine, my fists represent the single layer of epithelial cells within the small intestines. Now, during intestinal permeability, particular proteins that hold these cells together become disassembled due to the protein called zonulin. Now, zonulin release can be triggered via a number of different aspects, including gliadin, a protein found within wheat, and dysbiotic bacteria coming into contact with the enterocytes. Now, increased intestinal permeability can lead to the increased absorption of dietary antigens and lipopolysaccharides from gram-negative bacteria, also known as endotoxins. Now, this exposure can interfere with the host's immune system, stimulate inflammation, and lead to dysbiosis. So the implication intestinal permeability has on health and disease illustrates the importance of our research. Our research aims to explore and describe the conditions in which complementary and integrative medicine practitioners associate with intestinal permeability and the methods that they employ to assess intestinal permeability in clinical practice. Now, this can be broken down into three major objectives. The first of which is to explore the health conditions and diseases these complementary and integrative medicine practitioners observe to be associated with intestinal permeability. And then from there, what degree of clinical improvement do these practitioners observe after treating intestinal permeability? And lastly, to describe how, why, and when complementary and integrative medicine practitioners assess and test intestinal permeability. Now, this novel research project is the first to explore the health conditions and diseases complementary and integrative medicine practitioners associate with intestinal permeability and the methods that they employ to assess intestinal permeability within clinical practice. This is despite the emphasis of gastrointestinal health on or within naturopathic texts. There is no empirical evidence actually looking at intestinal permeability in clinical practice and what practitioners do, leaving a substantial knowledge gap. Now, therefore, the information obtained through our research project may actually address these knowledge gaps, providing an opportunity for improvement in clinical practice and indicate areas for future research. There are significant aspects of our project. So investigating complementary and integrative medicine practitioners' clinical experience of intestinal permeability may provide further understanding to a particular variety of areas within complementary and integrative medicine. First of which, it could lead to in vitro mechanistic research on the pathogenesis of intestinal permeability. It could lead to an expansion of clinical and epidemiological research looking at conditions that practitioners associate with intestinal permeability, yet not actually observed within the published literature. It could also lay the basis to the development of a validated diagnostic instrument that could be used in clinical practice to assess intestinal permeability. And finally, it may also suggest the time it takes to actually resolve intestinal permeability within clinical practice. This research has potential value for both complementary and conventional medicine. So the first step in addressing the research aims was to explore the conditions associated with intestinal permeability according to the published literature. Therefore, we conducted a systematic literature search up until April of this year in PubMed, Embase, and AMED. Articles were included if they were an epidemiological-based study assessing a particular health condition for intestinal permeability. After the inclusion and exclusion criteria were based on these articles, a total of 40 papers were included in the literature review. Now, our literature review revealed a number of key findings. The first of which is that intestinal permeability is strongly associated with autoimmune disease and liver conditions. So as depicted over in this table, you can see that a number of these autoimmune conditions include Crohn's disease, type 1 diabetes. The liver conditions involve non-alcoholic fatty liver disease, liver cirrhosis, and so forth. And it's been estimated, given the prevalence of intestinal permeability in these conditions, that if someone had one of these conditions isolated in our literature review, 1 in 3 individuals would actually have intestinal permeability. We further go on to discuss that disease severity and clinical symptoms correlate with intestinal permeability, meaning when there was a greater degree of intestinal permeability, that resulted in a greater degree of clinical symptoms, especially those related to menstrual disorders and food sensitivities. It also appears that the severity of intestinal permeability is exacerbated via dysbiosis, inflammation, and glucose metabolism disorders individually, meaning that when there's a presence of these 3 aspects, intestinal permeability is more severe. Therefore, we suggest that intestinal permeability should be considered as a differential diagnosis in autoimmune disease, liver-related conditions, polycystic ovarian syndrome, irritable bowel syndrome, diabetes, autism, food allergies, and food sensitivities. Now I'm going to discuss the methods that we implemented to gain the results of our study. The literature review actually laid the foundations for our study, and I'll talk about that a little more in depth a little later. A quantitative methodology approach employing a cross-sectional, self-administrated electronic survey was adopted for this study. This study was also approved by the Human Research and Ethics Committee of the Endeavour College of Natural Health. All right, the setting. We chose to set this study in PRACI, which is the Practitioner Research and Collaboration Initiative, which is actually designed for the collaboration between researchers and practitioners. So participants that were approached to be included in this study were members who identified as holding, members, might I say, of PRACI, who identified as holding a diploma qualification in either naturopathy, nutrition, or Western herbal medicine. The total source population was 227 potential applicants. Now, we recruited these applicants through Pracky. So Pracky actually emailed out an invitation to partake in the survey to all members meeting the eligibility criteria. Now, the survey was open for a 6-week period, and a follow-up email was sent 2 weeks after the initial invitation and 1 week before data collection was concluded. We did run a pilot test of the survey before we sent it out to the Pracky members, to 6 qualified practitioners who were not associated with Pracky, to assess language clarity, the time required to do the survey, and other minor details. The survey itself can be broken down into 3 major domains. The first of which looked at gender, where the participant actually practiced, their level and type of professional qualification, their hours spent in clinical practice, and their years of clinical experience. From there, we concluded a list of conditions. In total, there were 61 conditions to be a part of the survey. This list of conditions was based on our literature review and other epidemiological data. So these conditions became available for participants with a 5-point Likert scale to actually explore the degree that participants associate intestinal permeability with the particular condition. These same conditions became available again to explore the degree of improvement practitioners observed after treating intestinal permeability, with a scale ranging from no improvement to major improvement. And the last domain was looking at the testing methods utilised within clinical practice and the frequency of treatment. We utilised Survey Gizmo as a method to collect the data, and data analysis was reported in frequencies and percentages, with chi-square analysis done on basic demographics and comparing that to the observed time to resolve intestinal permeability. Now for the exciting part, the results. So now we're going to discuss the results of the study itself. First of all, we had a 15.9% response rate in a total of 36 participants who actually met the eligibility criteria and completed the survey. These participants were mainly females, with 80% being female, and majority of them practiced in either Victoria or New South Wales. Their level of professional qualification, majority of them had a bachelor degree or above, that's 58%, and majority of them had qualification in naturopathy, followed by nutrition, and then Western herbal medicine. Now, the years in clinical practice did vary. However, there was a mean of 11.5 years of clinical experience from participants. Furthermore, the hours spent in clinical practice range from 1 hour to over 30 hours, quite evenly distributed. Now, complementary and integrative medicine practitioners observed the greatest degree of association with gastrointestinal related conditions. That is, 100% of participants observed intestinal permeability to be associated with gastrointestinal related conditions. Now, this was followed closely by autoimmune diseases and skin conditions. Now, we actually look at the other end of the scale. Only 44% of participants actually observed an association between intestinal permeability and liver-related conditions. Now, I'm going to discuss this a little further, but just remember that 44%. Now, looking at the autoimmune disease conditions on an individual basis on their observed association to intestinal permeability, we can start over here at Crohn's disease. Just over 80% of participants observed there to be an association between intestinal permeability and Crohn's disease. Now, from that 80%, a further 90% illustrated that they observed a strong association between intestinal permeability and Crohn's disease. There's other ones, celiac disease, rheumatoid arthritis, all of these autoimmune diseases, above 50% observed that association. In relation to gastrointestinal conditions, you can see that irritable bowel syndrome and non-celiac gluten sensitivity, 90% of participants actually observed an association to intestinal permeability in these particular conditions, closely followed by food allergies and small intestinal bacteria overgrowth. All right, other health conditions. Here we have skin conditions such as eczema, acne, and dermatitis. Above 70% of participants observed an association. Now, as we come down here, we can see other conditions such as non-alcoholic fatty liver disease, polycystic ovarian syndrome, chronic liver disease. Now, these particular conditions, only about 30% observed an association. However, from that 30%, up to 50, sometimes 60% of those participants actually associate intestinal permeability to be strongly associated with these conditions. Unfortunately, there's been a technical issue with this diagram. However, I remember these stats. Now, this is a diagram looking at the improvement complementary and integrative medicine practitioners observe after treating intestinal permeability. The red, as you can clearly see, represents the major improvement. That is 33% of complementary and integrative medicine practitioners actually observed major clinical improvement in their condition after treating intestinal permeability. The blue here, that there is 60%. So 60% of participants actually observed a good improvement in the condition after treating intestinal permeability. And this green over here represents only 7% observing a slight improvement in intestinal permeability after treating intestinal permeability across the board in the conditions. Now, we can look at these on a more individual basis. So all of these conditions, participants observed a major clinical improvement after treating intestinal permeability. We can see here that just over 65% of participants observed a major clinical improvement after treating intestinal permeability and polycystic ovarian syndrome, followed by reflux, flatulence, type 2 diabetes, all the way down to small intestinal bacterial overgrowth. So just to re-elaborate, these particular conditions, practitioners observed a major clinical improvement after treating intestinal permeability. As for the good clinical improvement that participants observed, this most prevalent was the chronic liver disease, non-alcoholic fatty liver disease, hyperlipidemia. Above 50% of participants observed that treating intestinal permeability in these particular conditions resulted in a good clinical improvement of the actual disease itself. Now, looking at the signs and symptoms, this was quite interesting from my perspective. First of all, you've got food sensitivities. Now, almost 100%, that was 96% of participants observed that food sensitivities was a symptom of intestinal permeability, closely followed by intestinal dysbiosis and abdominal pain. What was interesting was the most prevalent conditions associated with intestinal permeability, the ones that had the highest observed association, were actually gastrointestinal related conditions, candida overgrowth, parasitis, bloating, and so forth. This table works. Now, looking at the treating and testing of intestinal permeability, 72% of participants would actually always or often treat intestinal permeability within their clinical practice. Now, however, no participants, that's 0%, would never or rarely treat. So participants are always or often treating and are not treating intestinal permeability. When we look on the other side at the frequency of actually testing for intestinal permeability, majority, that's 58%, would never or rarely actually test for intestinal permeability. within clinical practice. The most frequently used methods for testing intestinal permeability were the lactulose mannitol urinary test, with 47% saying that there was their preferred validated means of testing intestinal permeability, followed by a comprehensive digestive stool analysis, serum zonulin, hemaview, and then iridology. Now, there was a number of reasons why participants would actually suspect intestinal permeability in their clients, the most of which were patients' signs and symptoms. That is, 94% of participants actually use their patient's signs and symptoms as an indicator to suspect their patient may actually have intestinal permeability. This was closely followed by patient's medical history and then the disease in which the patient actually presents with. And if you can compare it on the other end of the scale, we actually have the validated method to actually evaluate intestinal permeability was quite not used to suspect intestinal permeability. So only 35% of participants would actually use a positive result or the results as such of this validated test to suspect intestinal permeability. There were a number of reasons why participants wouldn't test for intestinal permeability, the major of which was the price, the expensiveness of the test itself. They did suggest and state that they would just treat regardless of a positive or negative test result. Factors that actually influenced their decision to test for intestinal permeability was to support their patient's compliance in their treatment protocol. Now, looking at the time in which participants observed to resolve intestinal permeability, majority of participants, that's 47%, observed a 6-month period of treatment is required to resolve intestinal permeability, with a minimum of 3 months. So no participants stated or observed they can actually resolve intestinal permeability in either 1 or 2 months, meaning a minimum of 3 months is what they observe to be the time required to resolve intestinal permeability. Now, the time in which the treatment protocol is implemented before they would actually consider retesting, over 6 months. So practitioners who actually test intestinal permeability, they wouldn't actually do a retest until 6 months after the treatment has finished. All right, so they're the results. Let's now discuss them and explore their relevancy to both clinical practice, to research, and to actually where this information is situated in the current research knowledge. Complementary and integrative medicine practitioners observe an association between a wide variety of conditions, including conditions not recognized within the published literature. So I'm going to talk you through this table. Now, this middle column is the conditions which the published literature suggests are associated with intestinal permeability, along with the observed association from complementary and integrative medicine practitioners. Of such, we can see autoimmune disease pops up again. The most prevalent was gastrointestinal localized autoimmune diseases, such as IBD, inflammatory bowel disease, or celiac disease. Now, if we go to the other side, this is a list of all the conditions that practitioners observe to be associated with intestinal permeability. However, there is no conclusive evidence confirming any association. These include psoriasis, rheumatoid arthritis, non-celiac gluten sensitivity, all the way down to neurological conditions such as anxiety, ADHD, and depression. And then on the other side is these were the conditions found in our literature review to be associated with intestinal permeability. However, participants didn't observe an association. Now down the bottom, we have the conditions that were not associated to intestinal permeability. First of which, Parkinson's disease. Both published literature and complementary and integrative medicine practitioners observe that Parkinson's disease is not actually associated with intestinal permeability. Now, if we come down to here, published literature actually suggests that reflux isn't associated with intestinal permeability. However, we can see up here that practitioners observe reflux to be associated with intestinal permeability. So there are a number of reasons why this may actually occur, and one such reason is the co-occurrence of other conditions. So in clinical practice, reflux isn't seen individually. It generally occurs with another condition, like it co-occurs, generally with things like constipation or other digestive issues. So, and these other digestive issues, such as constipation, are associated with intestinal permeability. So there is that possibility that practitioners aren't actually able to distinguish whether the intestinal permeability was actually related to the reflux itself or to the other condition due to that clustering and co-occurrence. Based on our findings, complementary and integrative medicine practitioners utilize clinical signs and symptoms as the preferred method to evaluate and indicate intestinal permeability over validated diagnostic methods. Now, this suggests that a validated diagnostic instrument, such as a questionnaire or a survey, may be beneficial for both clinical practice and for research. Here we have the observed association between intestinal permeability and a condition, and the observed improvement that practitioners observe after they treat intestinal permeability in their clients. So our study suggests that a higher observed association with intestinal permeability correlates with a greater observed clinical improvement after treating intestinal permeability. Moreover, as the observed association to intestinal permeability reduces, so does the degree of clinical improvement. So we can see up here that the blue line represents the observed association to intestinal permeability, and the red line represents the degree of improvement. So as the association reduces, so does the observed improvement in intestinal permeability. Now, the treatment of intestinal permeability is multifactorial. There are genetic and environmental factors which are influencing the time that is actually required to resolve intestinal permeability. So intestinal permeability, resolving it may actually be a lengthy process. So our study suggests that practitioners observe a minimum of 3 months of treatment is required before intestinal permeability is resolved, with a further 6 months in some circumstances. Now, where does this research, if a newly graduated practitioner picks up this research, what can they gain from it? Well, first of all, newly graduated practitioners may actually read the study and be able to have an understanding of what their more experienced colleagues associate with intestinal permeability, what conditions to actually suspect intestinal permeability in. Also, what are the signs and symptoms that indicate intestinal permeability? So these newly graduated practitioners, they go, oh, food sensitivities, intestinal dysbiosis and bloating, these are all associated, have an observed association with intestinal permeability. According to my more experienced colleagues, it's probably worthwhile investigating this. Now, the time required to resolve intestinal permeability is another thing that these newly graduated practitioners are faced with. Actually, how long to implement a treatment protocol to resolve intestinal permeability. This research also has implication to practitioners within clinical practice. Now, remember that 44.4% of participants observed association between intestinal permeability and liver-related conditions. That leaves over 60% not observing an association between intestinal permeability and liver-related conditions. However, research, including our literature review, suggests that liver-related conditions are actually associated with intestinal permeability. So this information can be given to practitioners within clinical practice to say, hey, there may actually be an association with liver-related conditions. There may be a warrant to assess that in your clients with such a condition. We also provide, for research, a list of potential conditions that may be associated with intestinal permeability, according to practitioners. This list may actually lay the foundations to more research in intestinal permeability to actually understand the role that intestinal permeability plays within these particular conditions. Now, I've previously mentioned that it was observed that a minimum of 3 months is required to resolve intestinal permeability. This holds relevancy to the length in which clinical trials are set out over. So on average, a clinical trial assessing an intervention for the treatment of intestinal permeability can range anywhere from 4 to 12 weeks. However, if 3 months is the minimum time required to resolve intestinal permeability, according to the observation of practitioners, if a particular intervention, let's say probiotic X, was only tested for a 4-week period, that may actually not allow sufficient time to resolve or have a clinical change. So thereby, this information may actually lay the justification on the length in which a clinical trial may actually be conducted over. All right, so in terms of further direction of research, this validated diagnostic instrument, such as a survey or questionnaire that either practitioners can fill out for their patients or patients can fill out themselves, research needs to actually formulate this instrument based on the data that we've gathered here. From there, the instrument itself needs to be validated. It needs to be compared to other validated, probably more expensive tests, such as the lactulose and mannitol test and the serum zonulin, to determine the validity of the test. Now, once we actually have a validated diagnostic instrument, it can actually be given back to clinical practice as a cost-effective method to identify intestinal permeability in clinical practice, which actually addresses the major aspect that actually prevents practitioners from testing intestinal permeability in the first case, which was cost of the test. Now, this validated diagnostic instrument may also be given to clinical research. So as an example, you're evaluating a particular intervention using a serum zonulin or lactulose mannitol urinary test, and the results come back negative, saying that there was no association between this treatment intervention and intestinal permeability. If we had this validated diagnostic instrument with particular signs and symptoms that correspond with intestinal permeability, it would actually supply researchers with additional information to see if there was any change in symptoms known to be associated with intestinal permeability. Other research may evaluate, potentially using the same group of participants, what is actually improved after they treat intestinal permeability. Is it the severity of the disease? Is it digestive issues? Is it that there's less symptoms? What are the exact, precise aspects that are improved after treating intestinal permeability? Now, it's also worth exploring through observational research why there is a difference between observed association to intestinal permeability, according to practitioners, and published literature. One such theory behind this is that the conditions that practitioners observe to have a lower association to intestinal permeability may be less frequently seen within clinical practice, such as liver cirrhosis. It was shown in the published literature to be associated with intestinal permeability. However, practitioners don't associate it with it. So potentially individuals with liver cirrhosis don't actually see complementary and integrative medicine practitioners as their physician of choice to manage their disease. Other aspects for future research is to actually explore what supplements, lifestyle and dietary recommendations practitioners recommend for the treatment of intestinal permeability. And furthermore, does a particular treatment aspect result in a change in the time required to resolve intestinal permeability? We could also use a very similar survey to actually explore other health professionals, such as doctors or MST therapists, to see what they use in clinical practice, what conditions they associate with intestinal permeability. And all of this will support the whole system understanding of intestinal permeability. Now, just to conclude my honours research, we set out to answer a number of objectives, the first of which was to explore the health conditions and diseases complementary and integrative medicine practitioners associate with intestinal permeability in clinical practice. We answered this. We showed that there was quite a large list of conditions that participants observed to be associated with intestinal permeability, both in accordance with the literature and other conditions that weren't confirmed to be associated with intestinal permeability via larger epidemiological research. The second one was to explore the degree of clinical improvement after treating intestinal permeability. Now, we showed that up to 60%, I got that stat right, observed a good improvement after treating intestinal permeability in the conditions. 30% observed a major clinical improvement in the condition after treating intestinal permeability, with only 6.6% observing a slight improvement. Lastly was to describe how, why and when complementary and integrative medicine practitioners measure intestinal permeability. We showed that the lactulose mannitol urinary test was the most frequently used validated method to assess intestinal permeability. And we also showed that the reason that practitioners will actually test intestinal permeability wasn't to actually evaluate intestinal permeability, was actually to support their patients' compliance in their treatment protocol. However, the cost of the test itself was the greatest factor influencing practitioners not to test intestinal permeability. And that participants would not consider testing intestinal permeability, might I say retesting, until 6 months after treatment. Now, complementary and integrative medicine practitioners observe an association between intestinal permeability and conditions not yet recognised within the literature. The emphasis that complementary and integrative medicine practitioners place on patients' signs and symptoms as a means of suggesting intestinal permeability warrants the development of a validated diagnostic instrument. And finally, the experience that complementary and integrative medicine practitioners have observed through deductive reasoning holds potential value to the advancement of research and the clinical management of intestinal permeability. Now, I received an email about 12 hours ago stating that one of the papers that I wrote as part of my honours thesis was accepted for publication in the European Journal of Integrative Medicine. Safe to say I couldn't sleep last night. I could not have done this without the supervision of both Dr. Amy Steele and Dr. Janet Sloss. Their assistance throughout this whole process has made this experience such a positive and educational one. And I truly do appreciate all the support that you have given me throughout my honours thesis.